Good evening, everyone, and welcome. I'm Karen Parker, and I'm the project coordinator for community engagement of the RCMI program at Howard University College of Medicine. Of course, RCMI stands for Research Centers in Minority Institutions. I'm joined by my colleagues, Miranda and Ashley, and they're co-hosting with me, as well as Lance Reynolds on sound this evening. Miranda.
Thank you, Karen, and good evening to everyone who is joining us tonight. My name is Miranda Robinson Perez, and I'm the project manager for the Community Engagement Core at Howard University RCMI program. The Howard University Research Centers and Minority Institution program focuses on enhancing and developing necessary research infrastructure that ensures Howard University's ability to contribute to the resolution of diseases that disproportionately affect disadvantaged and minority populations. The Community Engagement Core's overarching goal is to ensure that RCMI-supported research addresses the needs and interests of the local community. To achieve this goal, the CEC partners with local community organizations to address health-related concerns, promotes community participation in research and partnership with researchers in study design and execution, while ensuring research findings are shared with relevant communities. This core is led by Dr. Carla Williams, who is not with us tonight, but is here with us in spirit.
Thank you, Miranda. Tonight, we're going to have an open, straight talk conversation about PASC, or long COVID. We have several guests with us to walk us through the quickly evolving set of information and what it means to us, as well as talk about the steps to get involved in the research that we do here at Howard University. As you can see by the slide on screen, PASC stands for Post-Acute Sequelae of SARS-CoV-2 Infection, or COVID. This evening, we're going to talk about what we currently know, whom long COVID affects and how, and ultimately what this means for our community. Our research presenter is Dr. Hassan Brim. He is a professor in our College of Medicine and a researcher at our Cancer Center, where his team focuses on the genetics and basics of gastrointestinal cancers, especially colorectal cancer. He's continued to contribute to COVID research and is going to share current data on long COVID. Please join me in welcoming Dr. Brim.
Thank you, Karen. Can you go to the first slide, please? Next one. Okay, so I have no conflicts of interest to disclose. Go please to the next. So one of the best ways to understand what PASC is first to simplify the terminology and to use the common language that you will find in the media, which is long haulers, long COVID, and you can also find the terminology post-COVID syndrome. These are all denoting exactly the same thing: long COVID, long haulers, post-COVID syndrome, or as Karen just explained, PASC, which is post-acute sequela. Sequela basically means remnants, something that stays after the acute phase. So for us to capture what this PASC is exactly, we have to go back at the start of the story, which is 2 years back, when the pandemic started. And we see how this have impacted the world in general, the US population, and in comparison, we see basically how parallel populations or continents have dealt with the pandemic, just to have a comparative mindset and some extra references. So worldwide right now, we put here the numbers from December, and there is a reason for that, because we want to capture it right before Omicron took over, because when the Omicron variant, and we're going to talk about variants in a few, that kind of leveled the picture around the globe. So these numbers are from December for the reason to see exactly what was the profile right before this huge wave of high transmissibility of the Omicron. So the US fared very badly compared to other places. We have one of the highest incidences, and we have also higher mortality. So in comparison from December to now we do have in the US 18 million cases, and we do have almost 1 million deaths compared to December, back in December. And if we take the picture on the world stage, so on the world stage right now, these numbers come to 500 million people who are infected and something like 6.3 million deaths. And go ahead, please, the next slide. So on the next slide, we are having two other places to compare exactly these numbers that we show on the US. So in Africa, somehow the population in Africa or the African continent fared very well with the pandemic. The number of cases was very low and the deaths also were low. So would that mean that the African genetics fared well with the pandemic? That's a possibility. But we can also speculate the African genetics in the environmental African continent fared well. Because when we're talking about our minorities, especially African Americans, they share the same genetics as Africans, but we have been living, or African Americans have been living in the US for some centuries, and these are affecting also the outcome of the genetics. Now, the starking example here that I took here is from New Zealand. So New Zealand, which is an isolated place, predominantly white population, it did not have a lot of cases and a very, very low number of deaths. So just by this comparison, that shows that here in the US, we must have done something wrong collectively or individually that shows this profile that we saw, which is high incidences and high mortality. And these incidences and mortalities also were different from different populations, and they were especially high in our African American populations and in the Hispanics, even though not in the early phase of the pandemic, but more so with the recent variants, especially with the Delta. Hispanics also were doing bad as the other population. Go ahead to the next slide, please. So the overview right now for the variants, when we talk about variants, basically because these creatures that are viruses, they mutate a lot. And when they mutate, we call those mutated new strains variants. And these variants have an impact because they might change the two main important factors for virus. One is transmissibility. For example, if you have noticed in the media and what happened since January, Omicron had a very high transmissibility. That means it was highly transmissible. And the second important character for a virus is virulence, or basically how it affects the host. And luckily for us, for example, this Omicron that was highly transmissible was associated with a very mild virulence and mild symptoms. And this is unlike the previous one. So if we can just keep in mind that basically what we are looking at here is mutations that happen in these viruses that generate new variants. Next slide, please. So for the pandemic management right now, I'm going to go quick over this. So there are right now vaccines that are available. Just to give a glimpse of where we are right now worldwide. So we have 11.1 billion vaccine doses that were given, which is not a lot compared to the 8 billion people that are living around the world. That means we are still open to the virus. And there are different cures that have been produced and can help in the management. So go ahead, please, next slide. So what I'm showing here right now is basically when somebody has the acute COVID-19, there are some symptoms that we are all familiar with that are showing up in these patients. We know fever, cough, runny nose, some headaches, some people show some digestive gastrointestinal symptoms. And remember that these symptoms, when we go ahead to the next slide, and compare these symptoms to the ones that show up in patients with PASC or with long COVID, we have a new set of symptoms. So we're not talking about fever anymore or headache, but we're talking about brain fog, which is basically people feel confused or loss of memory or lack of concentration. Some people show some gastrointestinal or digestive symptoms. Some people show some liver symptoms. Some people show some vision issues. So we are talking about a new set of symptoms that are different from the ones that we see when the symptoms are acute. Next slide, please. So the questions right now that need to be asked, which are those similar to the ones that Karen alluded to earlier and that are not answerable so far, because this is why we are doing these studies, is from all the people who have been infected, who gets PASC or who gets a long COVID or long hauler. There are some risk factors that we are working right now hard to find out exactly to know who is at risk for developing PASC or long COVID. And we want also to define what types of different long hauler profiles exist. Because as you can see in the next slide, go ahead. So in the next slide, what we did basically is we took some patients from Howard, to 88 patients who have COVID, and then we followed them over time, and we saw which type of basically of symptoms they keep showing up. So, and we found that 27 out of 88, which is about 27%, do keep showing some symptoms over a period of 6 to 9 months post-acute infection. And these symptoms ranging from neurological symptoms, digestive symptoms, pulmonary, breathing, and so on and so forth. So these are symptoms that were persistent. And if you go to the next slide, and the next slide is showing also a study on the same patients, which is showing the recurring symptoms. Recurring symptoms is that the symptom disappeared and then showed up 3 months or 9 months later, and after a period where it disappeared. So these kind of profiles and phenotypes of PASC are under study right now, and this is what we are why we are performing our studies at Howard as well as nationwide, so that one, we establish the incidence of long hauler or PASC, 2, we establish risk factors for it, and 3 is to understand the underlying pathophysiologies of PASC or long hauler. My last point here is going to be basically that I know that our communities, primarily minorities, African Americans and Hispanics, and I grow up also in a similar culture, we tend to be resilient, and that resilience is highly appreciated when generally. But when we are talking about the context of PASC, and we need to be, especially in this period, right post-pandemic, we need to be very alert to any change in our health, even if the changes are subtle, because those might be associated with post-COVID syndrome or long hauler status. And that's why we are doing this community engagement with the folks from the RCMI, so to raise awareness and to get people engaged in our studies. And I will stop here.
We are now going to open up our roundtable and have a conversation and hear from our guests. First up, we have Dr. Arienka Layemo, who is a gastroenterology specialist and a principal investigator at Howard University here. We have Daniel Carrell, an osteopath and infectious disease specialist, and one of the 3 lead clinicians for the COVID-19 recovery clinic at George Washington University Medical Center downtown in DC. We also have Dr. Geb Teferi, who is an infectious disease specialist at Unity Healthcare in Parkside, Stanton Road Health Center, Brentwood Health Center, and also Unity at Federal City CCNV. So the individuals that I've just named are really some of our frontline warriors in this battle, and they're here to share some of their insights from their clinical experiences. So please welcome them. Cameras on, please, gentlemen.
Thank you for having me.
Absolutely. So I'm just going to put this first question out to all of the clinicians that are at our roundtable. What is the threshold, in your view, over which a recovery path from COVID becomes PASC? And then I have a follow-up to that. What can we, as those of us who have been diagnosed with COVID, what can we do to protect ourselves, knowing that we're all exposed daily, the numbers are rising, and we're moving right into another surge? Please.
Maybe I can start. Thank you for the introduction. So going back a little bit from Dr. Brim's presentation, there are 6 million or so deaths worldwide and close to 1 million in USA. But that's from reported cases. People have to realize there are more dead people because of COVID. And there is what they call a concept of excess death, which means from year to year, they know how many people would die in that year. But when they compare it, there is extra number of people dying beyond expectation. And at one study, they looked at those people and they found out it's COVID. So the estimation, don't be alarmed, the estimation actually worldwide is 3 times what is reported. So this is a huge problem, we have to know. The second thing I would like to emphasize is, since we're talking with minorities, there is one thing clear, which is reported and observed, which is the disparity in COVID treatment and management. Even CDC reported in their MMWR, what they saw is when minorities present to hospitals or treatment centers, there are medications people get before they get seriously sick to avoid further sickness. So when they looked at the data, minorities didn't get those medications and they end up in the hospital. They shouldn't be there. The good thing is once they are inside the hospital, the management is the same. The other, I saw a report, actually, probably Dr. Carl maybe helped me out in a report, even from GW here locally, in their long COVID clinic, the users of that long COVID clinics way out of the minority. So we have to know. Regarding your question, who gets long COVID, it is not known who gets it. One thing is clear, people who are really sick, who are intubated, who are in the ICU, they are more at risk to get long COVID. At the get-go, the fact that they were in the hospital seriously, it has its own complication which lingers behind. And the definition of long COVID is when somebody has symptoms 28 days after the original infection. So we don't know. So the best thing, to be honest, the best thing is, remember what I said, who gets treatment, how do we get it, considering all those factors, and then even the data showing more minority getting sick, getting infected, dying from it. Some of it is not like a genetic, some of it is the way we live. Minorities cannot afford to work on Zoom. They have to go out, meet people, and they live in crowded situations, so the infection spread is easily among them. So to prevent infection or prevent from getting the COVID, second important thing is take the COVID vaccine seriously. There is a data which shows people who got the vaccine, they may reduce potential of getting into long COVID by 50%. So that's what I advise from what I know.
Yes, thank you so much, Dr. Tafiri. I completely agree with everything you said. By the way, this is Daniel Carroll talking. Again, I'm an internist at George Washington and one of the members of our long COVID clinic over there. And I think you brought up a really interesting point when you said, talking about like the population that are generally seen at long COVID clinics, not just here at GW, but certainly at other places like, you know, Hopkins and places around the country, certainly that have long COVID clinics. And it doesn't certainly, you know, it is a little bit of a self-selecting, much wealthier population, much less likely to be people of color. Certainly it's a problem we noticed from the get-go. And we presented this data actually at GW Research Day last year, discussing this as kind of a problem and basically accessibility, which is, you know, it's basically can be so harmful to, you know, certain subgroups of people, you know, especially as you said, it's not just the people, like minorities, people of color, people who are poor. It's not just that they're more likely to get sick, it's that they have the pre-existing conditions, such as diabetes is not well controlled, blood pressure is not well controlled, that's going to make their course of COVID so much worse. And I don't know what the data is exactly on this, because there's not a lot of data on long COVID published, but you know, it certainly is, you know, I'm sure that makes long COVID so much worse.
Yeah.
And so, yeah, at long COVID, I think now the working definition we've been going off of, we've kind of extended it like long COVID to be about 3 months after the initial infection. And the reason I think is just because of the number of people who have symptoms following an acute infection is just so high, as, you know, as estimates are as high as about a third of people have symptoms 2 or 3 months following initial infection with COVID. Yeah, and another point that was brought up, I just wanted to touch on also, is that everybody's long COVID looks different. So like, how do you know you're experiencing long COVID? That's a great question. We don't have a scientific answer on that. Anybody having symptoms essentially that are continuing that they didn't have before COVID, I would say possibly has long COVID and could be evaluated for long COVID. And then I think that there is definitely a difference, but you know, it's important to differentiate between the acute phase and the long phase, even though for some patients I've seen there's a very clear delineation. There are people that kind of just got COVID, got better, and then had these symptoms like fatigue and brain fog. And there are patients who just got COVID and they feel like they still have COVID 3, 4, 5, 6 months later. So like, I just want to emphasize that it can look so different depending upon who the person is and the person's, you know, underlying characteristics and all that stuff. And, you know, the human body is incredibly complex, and yeah, it's gonna be really hard to tease all that out, certainly.
Thank you. And we have a question that's come up in the chat from Bonnie Harris. He's asking, at what point does an individual know that they are experiencing long COVID? And I think I heard that it was once you have symptoms that have gone past the 28-day mark. Is that so? I heard 28 days and then I heard something else. So could you clarify that, please?
Probably I can clarify that. So there are maybe 3 ways people go into long COVID. Once people get new infection, they were feeling the symptoms and so on. Past 28 days, if the symptom lingers, then they are going into a long COVID regime. And those who are really sick in the ICU, intubated and so on, they pretty much they have those long COVID kind of symptoms because of their stay in the hospital in critical care. So when they go out, they may have those signs, symptoms. But remember, there are other group of people. They don't even know they had COVID because they didn't have any sign symptom. But then later on, could be past 1 month to 3, like Dr. Daniel said, they could feel symptoms. And so that way, the people may realize they have symptoms. One thing that COVID does is, if somebody has an underlying disease, which was not a problem at the get-go, but then after COVID, that disease, which was in some, would be flaring up and will come out. It's not long COVID, but it's just the outcome of a COVID inflammatory process. So there are 3 ways. So how someone would know they had long COVID? If they never had any sign symptom, all of a sudden they start to feel sick, they should suspect. Even those who are asymptomatic, they can check, go to their providers, find out if they were infected with long COVID. The first thing we do actually is to make sure that whatever our patients are feeling or complaining is not COVID could it be some other thing? Because you just can't label it as COVID and then sit on it, because it could be some other serious illness. So that's, if you feel symptoms, that's how you may suspect you may have COVID. I see a question in there. There could be a mild to serious illness. Remember, this COVID infection goes to all of our body. It affects every system of our body. So depending on which system is affected more, people may show signs, symptoms of what we call central nervous system, what we call cardiovascular system, and what we call respiratory system, even gastrointestinal system. So people may present in different ways. Some may have mild, but the most common people complain is fatigue is one. The other very common is what we call brain fog. Brain fog is like lack of attention. You get up to do something in the middle of your work, you forgot what you do it. Actually, I remember one patient described it very well. She said driving, she makes a left turn light, but when she reaches at the cross section, she just keeps driving. Just forget it. So it depends. I have patients actually who are long COVID. They have fast heartbeat. They couldn't stand. They sit down, dizzy. So it could get serious. It could be just very mild. In most instances, it may go away in 6 months. But some people, it's just all over. But everybody has to have a high level of alert, especially those people who are healthy, have nothing, or don't have underlying problem. They feel something, they should suspect, could it be, and then seek care.
Thank you for that. We have a couple of more questions coming up in the chat. This is great. People really have questions. The first is, are patients with PASC able to transmit COVID?
If I might address that one. So patients with PASC, let me go back to 3 ways that PASC is being explained right now. One is, they say that there is one hypothesis that says that the virus maintains itself in the body, and there are some evidence for that. Another one is that there is the inflammation that was triggered by the acute infection. Its effects are associated with this long hauler or PASC. And the third one is that there is some kind of persistent mediators of inflammation that keeps being expressed in these patients, and that associate with the long COVID or PASC. So even with the 3 hypotheses here right now, none of them supports that PASC patients will be transmitting the virus, because if you take any respiratory or specimens, they will show negative. So that means they will not be able to transmit it directly. But going back to what one of the people who just intervened right now stated is, we might be transferring it because as of now, for example, we have 80 million people are reported to have been infected, but the real number is most likely double that, because millions of people have been infected and were symptomatic, or some who had some symptoms but were never reported. So basically, the virus is still flowing everywhere. In regards to the question about the threshold, that one is a very important one. The thresholds right now, and we are involved in this NIH Recover study where we are struggling right now to define what is the threshold to dissociate patients with from those without PASC. The best metric for the threshold is the patient himself or herself. And this is why in my concluding statement, I stated that patients need to be alert about any changes in their own health, even if those changes are subtle. That's the only way that you can catch a potential PASC or potential long hauler phenotype. But the threshold will be different from one patient to another, depending on age, depending on comorbidities, as was stated right now before, and depending on the course of COVID itself. So patients who have had severe one are likely to be experiencing more PASC, more long hauler than the ones that have had mild one. And I will stop here.
Thank you, Dr. Brim. We have one more question. I think it may have been addressed before, but just to make very clear, does long or mild COVID affect the memory?
I would say
I see
yes.
you nodding, Dr. Carroll.
Yeah, it definitely can. I mean, not for everybody. Again, every person is different. But yeah, absolutely. I've seen it in my clinic affect memory of some amount of patients. It's one of the more common symptoms for sure.
Just a little bit about inflammation. We have to understand when somebody is infected with SARS-CoV virus, the body tries to get rid of this virus, but what it does is it excretes or releases this antivirus inflammatory markers we call excessively beyond what the normal mechanism is. So in the process, that increased inflammation in the body starts to affect, injure our own body. I mean, there are other diseases. We have to know what we call autoimmune diseases. Our own body fails to recognize our own body and starts to attack its own cells. So that's the reason behind all this long COVID, one of course, but even for the severe sickness, one of it, especially when it comes to central nervous system, the brain, there is a lot of inflammatory markers released and they damage the blood vessels start to leak, and people do come with stroke and other lingering signs, symptoms. So it's overreaction of our body to the virus, which makes us sick actually. So we don't know who's going to overreact. We don't know who's going to take it as it is and have no sign symptom. So it's better to not to get COVID, to be honest.
Thank you for that really important point, Dr. Teferi. So regardless of whether it's mild or not, the whole point is to avoid getting it in the first place because it's such a gamble. I'm going to put this next question to Dr. Laiamo because he's been quiet and he's got an amazing voice. We do have another question that has come up in the chat, and that is, what kinds of treatments are offered in a long COVID clinic?
Thank you very much for that question. Actually, I just unmuted myself because I wanted to continue where Dr. Teferi actually stopped in terms of preventing COVID is the way to go, using every tool that you could, so that if you don't have COVID, we don't have to talk about post-COVID, right? So because I still know, I mean, quite shockingly, there are still some people who are still older from vaccination. And not too long ago, we actually, before it was made mandatory that you just have to be vaccinated as a reason for employment and all those stuff, we actually conducted a study 1 year, into the pandemic when vaccine was already available. And we realized many people who are even healthcare workers were holdouts. I mean, and that was shocking to us. That was shocking. So if you are vaccinated and you still get COVID, because that's part of what people sometimes want to throw out there, that people who are vaccinated still got COVID. So there was the point. But what people often fail to realize is when you are vaccinated against the disease, it's not necessarily that the disease, you have become completely 100% immune to it. It just gives you a very good fighting chance against the disease. And in terms of COVID, we know that those who are vaccinated, they are less likely to die from COVID. Those who are vaccinated, they are less likely to get long COVID. Their risk reduces. So the first message I wanted to just pass before even coming to whether we have treatment or we don't have treatment is, why not let's try our best to prevent? And we already have very good, very effective vaccines that have shown in trials and even in population studies that these vaccines are effective. anything that we can do to get to 100% vaccination rate would be very good. This would be something that we should still continue to emphasize, because you'll be surprised there are still some people who are holdouts. And an anesthesiologist shared something with me, that there was a guy that was shot, bullet, shot. And they were rushing into the OR for surgery, and they gave him tetanus injection, tetanus shot. And the guy rose his head and said, I hope that's not COVID shot. I hope that's not COVID shot. And that they were all astonished. You got shot with bullets, and you want to be arguing just to make sure that this is not COVID vaccine shot. You can imagine that. I mean, I know SHOT is SHOT, but they are shots and they are shots. You got shot with a bullet. Okay, so it just blew my mind when the anesthesiologist shared that with me. So we still have that message. We still need to emphasize that even though COVID may appear that it may be going down, but those who are not vaccinated, we should still encourage them to go get the vaccines. And then when it comes to booster shots too, those who didn't get the booster, we should encourage them. Now, coming to the question being asked itself, in terms of what kind of treatments are offered, I'm going to actually defer to the infectious disease doctors, and we are fortunate to have them on the panel and some people running the COVID clinic. But in terms of if you don't have a particular medicine that can treat the causative organism, anything else you are going to be doing is going to be symptomatic for whatever problem the people present with, until you're able to get rid of the particular organism causing the problem and whatever is the sequelae of the effect of that particular organism. So if we eliminate the virus itself, like I said, we don't have to worry about post-virus problem. But if the virus is already there, then we can manage whatever is the problem that it is then presenting. And more often than not, that will just be in terms of symptomatic treatment for whatever is the ongoing problem that the patient will present with. Rehabilitation also will be important for those who feel weak. Supportive treatment in terms of keeping, for those who will have orthostatic blood pressure changes, they feel dizzy if they rise suddenly, so they have to adjust, to make sure that they stay safe so that you don't rise rapidly. So everything is going to be based on what the person is presenting with. But that said, I'm going to defer to the infectious disease specialist, who I have an infectious disease friend, and I asked not too long ago, I said, when are you guys going to get rid of this COVID for all of us? So I'll defer to my colleagues on that.
Yeah, I think that's a really good point. The last thing you said, I think, is really important. It really depends on in terms of what treatments we can offer. It's kind of whatever, it's what is needed most for the patient. And it really does vary quite a bit between different patients. So for example, if a patient has a primarily kind of those, what we call POTS symptoms, POTS is POTS. And that is kind of when you feel palpitations or you feel dizzy upon standing, and for some reason your heart rate becomes really high. We do a number of things with those patients. For example, we discuss the importance of taking in an appropriate amount of salt and water and making sure that they're keeping their hydration status quite up to par, because we know if you're dehydrated, those symptoms can get much, much worse. We consider sometimes medicines like beta blockers to kind of keep the heart rate and hence the symptoms under control, which we've seen actually work pretty well for a lot of people. There's other medicines that can increase blood pressure that we use sometimes. It's not our favorite thing because those medicines can certainly have side effects, and they're very hard to use with people who have high blood pressure. So for patients like that, we have a number of things we can offer, including both lifestyle stuff and medications as well. For patients who primarily come with like the fatigue and brain fog, we very much have like a neuro/rehab focused plan. And here at GW, we're very fortunate, and other places too, certainly very fortunate to have some really wonderful physical therapists who really have become very familiar with helping patients who've had long COVID and suffer from fatigue and inability to kind of do small amounts of exercise, really help them improve slowly over time, of course, because you don't want to push too hard and kind of make the person feel worse. So we have wonderful resources with physical therapy and physical medicine and rehabilitation, which again, GW, I know some of them personally, and they're truly wonderful. And then we also have our speech language pathology folks who do cognitive exercises specifically for people with memory deficits, and people have really a hard time with memory and the brain fog symptoms. So I've seen people do well and make, you know, improvements in those things. I mean, with those symptoms. I mean, I think also there are other medications. For example, there's a class of medications called SSRIs, which are actually antidepressants initially developed, but there's literature that suggests they can be used effectively with people with neurologic issues, for example, patients in stroke. And we've started using for certain patients, we can use those medicines sometimes, which can help. And our theory is it kind of maybe moves along the neurologic recovery process. And a lot of what we do also, we do a lot of education. We talk about what long COVID is, why people get it, kind of the long-term prognosis and stuff like that. So that's a big part of it too. And of course, really important, I can't say this enough, is that a lot of the patients, we want to make sure that their normal healthcare stuff is in order. Like, for example, if they have high blood pressure, we want to make sure it's treated. We want to make sure we screen them for diabetes. We want to make sure we do all the normal stuff and, you know, do a full investigation of the fatigue, make sure their thyroid's okay, right? Stuff like that. You know, so we want to make sure we do a full evaluation, I mean, of the patient to make sure that they're getting the right medical care to begin with, because if they're not getting the right medical care, we can't really talk about long COVID yet. So that's a big part of what we do also. I hope that answers the question. I know it's kind of, you know, there's the truth is there's a number of things we can do, and it really is very dependent on what the person, what the, you know, the human being in front of you is suffering from the most.
What they're coming in the door with.
Absolutely.
Thank you so much. This is such a great conversation. We still have more questions coming through. So I want to make sure that we're addressing everything that comes through, plus some other questions. But back to Dr. Laemo's point about needing to be vaccinated. There are people, there is a segment of the population with autoimmune disorders, et cetera, who have been advised to not be vaccinated. So I've got two questions that surround that. The first is, what impact have you observed with PASC and autoimmune diseases? And the follow-on to that is, what happens to someone who cannot be vaccinated, but they have PASC?
So, and I'll appreciate when the infectious disease doctors also put in, you know, some contributions to this. But in terms of what the literature has been showing, people who have autoimmune diseases, they actually suffer a little more. Okay, they suffer more from COVID, and that's it's a little bit easy to understand why, because they already have autoimmune problems. And if COVID is also going to trigger autoimmune reaction, then it means they are getting like a double hit, kind of. So it's not everybody, because the segment of the population with autoimmune diseases is actually not that many for robust studies to be done. But some of the evidence we see in the literature is that those who have autoimmune problems, they tend to have more challenges in terms of recovery. However, so if somebody has been advised not to, okay, because there are some diseases that not necessarily will preclude you from actually getting COVID vaccine. If anything, those people who are on immunosuppressants and stuff like that are actually encouraged to actually get COVID vaccine in the beginning, even. So like our patients that have things like Crohn's disease, they are encouraged to actually get COVID. So it's not all people with autoimmune problems. So I'm going to take that person who asked the question is in a particular unique situation. And I am not an expert in vaccine or in autoimmune disease to pass a specific answer to that. But what I know in general, as part of the overall benefit of the society itself, is the goal of vaccination throughout is mainly to also get to herd immunity, which means when most people are vaccinated and if the ability to actually transmit the virus will go down. So for the segment of the population that have been advised not to get it by their care providers, because that's the way I'm thinking of the question. Not that my neighbor told me when I got COVID vaccine is when I became sick. Because sometimes you have people sharing anecdotes that sometimes do not have scientific basis. Sometimes we do that a lot with the flu shot. That you see people that will swear that it's only the year that they get flu shot that they get the flu. Okay, but that's that person's experience. So you can't think they are lying, but you know that for most people that's not what really happens. So it may be a case by case thing. So I'm going to assume that the person who cannot be vaccinated is because of their specific condition. And all I will say is, well, be healthy in everything else that you can be healthy in. Like Dr. Karen mentioned, if you have diabetes, have it controlled well. If you have high blood pressure, have it controlled well. If you have other comorbidities, be on top of those ones. At least have a baseline, very good health in those things that you can still manage. And we hope that when most people are vaccinated and they don't actually contract the virus enough to pass it around, then those people will be protected under the herd immunity effect that will occur with most people when they live in an environment where most people are already well vaccinated. So that's as much as I know, but the infectious disease specialist can give more information about that.
I think you have said it. Pretty much the contraindication or people who shouldn't get COVID vaccine is very much limited, even in people with autoimmune or rheumatological diseases, even those people who have transplant and they take immunosuppressant medications, they take COVID vaccine. The problem with those people is after taking the COVID vaccine, would they develop enough antibody? And the studies show certain segment of the population, even after taking 2 doses, they have zero immunity. So that's where actually the 3rd, 4th dose idea came up. So autoimmune as such is not a contraindication. And the first thing what we have to ask is when we give vaccine, is it safe? The first thing is it safe? So I can stop actually on the next question, if you allow me, Karen. A second booster shots recommended?
Yes.
Yeah.
Yes, please do.
This is actually, I myself was like asking what happens if somebody takes a 4th shot. So there was clearly a study which came from Israel. And those people are very aggressive. They have vaccinated their population with Pfizer vaccine, and they vaccinated people above the age of 60 with 4th dose. So the first thing they saw was, is it safe enough? Yeah, it was safe enough. There was no question about it. It was safe enough. There was no difference between prior vaccinations and the 4th dose. And the second question is, can it protect people from getting COVID infection or SARS-CoV infection? The other question is how much strong it is to protect people from getting into serious sickness. So regarding protecting people from infection, it does, but it is short-lived. After 3-4 months, the antibody level goes down and the protection will disappear or gets very low. What we saw with all these vaccines, remember everybody, what we saw, the benefit from all these vaccines in people who took the vaccine, they are protected from getting serious illness. It protects them into getting from the hospital, or it protects them from this. So according to the Israel data, the 4th vaccine really protected people from getting serious illness. So it is recommended. By now, it is based on age, 50 years old or those who are younger who have some comorbid situation, if they get SARS-CoV infection, they would have they would be at risk to develop serious infection. So it is recommended and it is safe. It is safe to take it, the second booster. Just one more thing to start regarding long COVID treatment. I know Dr. Carol has actually more than enough explained it, but treating long COVID is not your traditional one doctor and the patient. It is treated by multi-specialties, group of other doctors, because it involves a lot of systems in your body. It's not one doctor or one specialist who's treating you. I guess Dr. Carl can mention that the lung doctor, the rheumatologist, everybody, the neurologist, the heart doctor is involved. You have to realize that. So try to avoid that. One thing, if I extend to advise the communities, Dr. Brim has mentioned it. Why do minorities get more sick or die from it? Because they have comorbidities. How about changing our lifestyle, doing a healthy lifestyle, exercise, cut down with the carbon food and avoid those illnesses like hypertension, diabetes, and so on. That way you stay away from the hospital actually. I cautiously warn people, the system is not good enough to handle everybody. It's not good enough. There is disparity already. And when it comes to COVID, you have seen it. The system may be overwhelmed too. So even though there could be a treatment, the system would be overwhelmed and people may not get the right treatment. So extending it back to the community, which has much more of those comorbid situations, let's change our lifestyle. That's my advice though. Thank you.
Thank you for that. And I actually have a follow-on question to this part of the conversation, two follow-on questions. One is on the concept of herd immunity, because I'm not sure that I know whether the definition of herd immunity can be applied in a situation where we have this continuing evolution of the virus.
Yeah.
And every time we turn around and things seem to get a little bit more peaceful, even now, there's a new wave that's here. And many people are unaware of it because they simply have decided that they're tired of COVID. And in that sense, there is a question here. Is it possible to achieve herd immunity in an environment where people are not actively seeking this vaccination? That's point one.
Yeah.
Point two is, in a society such as ours, where we are in danger of losing funding that underwrites this care, because we're currently under emergency status, but that's going to be going away. So when you talk about having these various providers giving care, et cetera, how is that going to look when the funding goes away? It's probably already gone away.
I might address your question, the first one, which is basically about the herd community or the herd immunity. So I gave some numbers earlier that so far, if you go check the data, there's 11.1 billion vaccine doses that have been given worldwide. And we are talking about 8 billion people on the globe. If we pay attention, for example, both of the latest waves, both the Delta and Omicron. Delta showed up in India and ended up everywhere. And Omicron showed up in South Africa and ended up everywhere right now. So this is why we have to take this word of herd immunity very, very carefully. We're not talking within the borders of one state or one country or even one continent. Viruses knows no borders. Right now, we live in the small village, so whatever shows up in one corner of the world ends up in the other one. But as far as our own behavior, and this is why I stated earlier that we are culprit to a certain extent of the situation of the pandemic, of the numbers of the pandemic in the US, because there is definitely something in our collective and individual behavior that makes our profile of the pandemic much worse than the one in New Zealand and than the one in many other parts of the world. So there is something about the management of the pandemic, whether it is from policy level or from even individual levels. So my take on that right now is that while people are tired of the pandemic and while people thinking that it's over, any lowering guard from now until the end of 2022 is just going to be allowing a resurgence of the pandemic, and we already see it again. Many states are putting masks again on indoor. So we still have to keep our guards on, and we have to think beyond our borders to think that this is a global pandemic problem and issue. So we are not out of the woods yet, and there is still a lot of work that we have to do to safeguard ourselves, in addition to the vaccine, adding also the other safeguards as well.
Just here to add on what Dr. Brim said, clearly there are actually studies where they looked at if somebody was infected with the original virus, could he have protective antibody for the subsequent virus? No, they didn't see that. But actually, if you are infected with the newcomer, you have much more protection with the old viruses. So because of the mutation, you touched it without saying it. Herd immunity is not gonna work, to be honest, because the new viruses have mutated. You can see from 2 vaccines, we're jumping to 3 vaccines. It's not only the vaccine which is affected, the treatments are affected too. There are this group of medications called monoclonal antibodies. By Delta, some of them out of picture. By Omicron, some of them are out of picture. So if we have the original virus, then we may have a herd immunity against infection. But if the virus is changing its behavior, genetic code, we don't have. What we see probably is there are 2 ways the body protects us from infection and disease. One is the antibody. There is another thing called cell-mediated immunity, which actually protects us from having a serious illness. Probably that part of it may have a role, even though somebody is not protected from infection. Maybe past infection may help them from in making the disease much milder than serious illness. Regarding your second question, I know this grant every money is going to go away. So the strategy is to integrate this COVID care into the normal clinics. So in Unity, we're trying to do that. What we're trying to do is, one thing everybody has to realize, this thing is a dynamic thing. Not every provider knows about it that much. Not the patients don't know it. So we're to go proactively look for patients who may have had long COVID, but they're staying at home. So integrating it into the routine medical care. The problem is once they are identified with long COVID, like I said, to send to Dr. Kraus' clinic, it needs a referral, it needs a multidisciplinary approach. That's where the issue is, but the best thing is what you do now. What you do now is one of them. Increased awareness of it. Because what happens is somebody may have sign symptoms, go around, may be examined, investigated for a different thing, when it could be just COVID, post-COVID only. Or sometimes they may have post-COVID, it may be labeled post-COVID, there may be other serious things. So I think one of us say the patient is the threshold for this. So the awareness, what you do is great. And then integrating this care, like we did with HIV and other illnesses, integrate it in the routine medical practice or healthcare institution. Thank you.
Yeah, that's so important. I mean, can you imagine like a situation where you have to go to one of a few physicians at a major academic center to treat a disease that's extremely prevalent and that's just all over the place? To me, it's just, number one, going to contribute to inequality. I mean, we've seen the pandemic has shown us how truly unequal our society is from the, forget COVID, just in general. And then, to have a situation where only people who have resources can actually access this kind of care. And then even in that situation, waiting 6 months, 7 months to get an appointment with a long COVID specialist doesn't really make any sense. because it's not really a subspecialty in that sense. It is in the purview of every physician across all the specialties, because as everyone's kind of been saying, it does affect every system. And of course, as us, I'm a general internal medicine doctor. So I'm, not really kind of master of none, but the truth is, I think that's, I think general internal medicine, family medicine, kind of the general practice, kind of doctors and providers are really, I think, especially well equipped to kind of become the quarterback, so to speak, because, you listen to kind of the trick is listen to the patient. We'll find out what do they need? What do they need addressed? And then from there, make the plan. And that plan is almost surely going to involve specialists at some point. But I think having, doctors, physicians, and NPs and PAs and the whole team really being educated and understanding what long COVID is and how to approach it, I think is just so important. And as doctors, I think we haven't done a great, for the most part, I wouldn't give us stellar grades in terms of being competent in dealing with this kind of second pandemic of long COVID. I think there's just too many doctors. I've had so many patients tell me like that they've been blown off by their doctor, or their doctor kind of just says, "Oh, it's in your head," or something like that. And just me saying, yeah, it's a physiologic thing is so kind of freeing for them to hear that. So I think as we as healthcare people, we have to do a little bit of a better job in knowing what this is and knowing how to treat it. And it's not something that's only treated at the Johns Hopkins. It's gonna have to be treated everywhere in the community, in the city, everywhere across the country and across the world.
Thank you. Thank you for that global response. I really appreciate it. And I'm checking the time. I want to pause here just slightly and thank everyone for your questions and for hanging in here. We have another guest that I would like to bring forward. He's going to bring a slightly different perspective. He's going to help us kind of talk about the everyday. He's a pillar in our DC community. His name is Stuart Anderson, and he is, I think the best way to describe him is a change agent. He's the founder of Friends and Family of Incarcerated Persons, and he is also an avid wellness activist in our city. Mr. Anderson, welcome to the roundtable. You are live.
Thank you very much. I appreciate this opportunity to address the group. I think that the doctors have done a wonderful thing. I'm the only lay guy, I think, that's actually a panelist in regards to this very important topic on long COVID. The number one thing that I think I want to bring to this conversation is that there was just this conversation about this herd mentality and idea, and the importance of how we need to have everybody who is in our community aware of the dangers of not keeping our eye and our minds focused on this long COVID and the effects of long COVID, and get more people educated. So the idea of having these smaller, long centers will be a wonderful way of reaching the average individual who doesn't get a lot of clinical information and understanding of how serious it is. So I thank you for having me. I'm free to answer any questions. Do want to say that we definitely have to, just as we have to do the same thing with mental health, we have to figure out how do we package the delivery of addressing long COVID, the potential effects of long COVID, and how do we get more people tested? We just heard how we are outpacing some other countries around the globe when it comes to the number of people who are infected, the number of people who don't get tested. And I don't think there was a clear answer, and I did want to point this out, to what about these multiple boosters? And maybe the doctors can chime back in and say, do we need to get a second and third booster shot? And if so, how important is that? I just throw that question back, but I'm here to answer any questions from the lay perspective and the average guy on the concrete of what I believe we should be doing to help people stay tuned, stay focused, and get involved in fighting and pushing back on this COVID so that we all have a safer life to live.
I think it's good to go back to that question that you mentioned, Stuart. It was discussed earlier, but to your point, you want to underscore the importance of having the second and third follow-on injection. Is that correct?
Yes, that's correct. That was one of the questions I saw in the chat. And maybe it was answered before the question got in there, and that's why I didn't hear it after I saw the question, right? But there was a specific question about these second and third booster shots and the value of having those shots and getting those shots.
Dr. Laemo, it looks like you want to address that.
So like Dr. Perry mentioned about the paper that was actually published from Israel, people, when they gave the second booster, okay, so that would mean these people will have got 4 shots now. So that one was just published about a week ago or so. But what it showed was that they still had added benefit in terms of reducing the severity of disease for those who actually got booster. Now, so there may be added benefits, but the people right now, there are people who they are selected people in terms of, it's not like widespread general that is already recommended in terms of booster, the first round booster, which make 3 doses, but like the 4th dose or the 5th dose or whatever additional doses will come in the future, which we don't know yet. But so far, what that study showed was that the 4th dose was safe. That's number 1. And number 2, there's an added layer that it gave in terms of reducing severity. So we still have to look for more studies to know exactly what the recommendations will be widespread for everybody else. But for right now, it's more in terms of specific groups. So we don't know what will happen in the future, but at least my own take on it is still that those who are yet to be vaccinated at all, we should still continue to emphasize those ones, because those are still the ones that are more likely to get the most, the worst outcomes from COVID if they get it. Those will be people who are not vaccinated at all. So, and there are still some of them remaining that we do know, and we do come across them once in a while, that this person is not vaccinated at all. They didn't even get a single shot. So I think we should emphasize a lot more on those ones, those who didn't get any vaccine at all. So that even if they get the first shot, the second shot, and then the booster, then we can worry about 4th shot, 5th shot, or whatever else shot that needs to come thereafter. But the first and the second doses and the 3rd dose, at least people should be encouraged to get those ones. We should strive for 100% in those ones, at least because we know those ones really benefit at this point.
Thank you, Dr. Laemo. And we have a question for Mr. Anderson from Dr. Williams.
Yeah, I saw that question. I just was reading that question. So, Dr. Williams, some of the things that are being played out in the community have to do with kind of age-old fears of, number one, and I'm going to speak about Black men first. So, historically, men in general and Black men specifically, for whatever reasons, I guess it's upbringing and everything like that, and the kind of patriarchal kind of thing about strong men and ideas like that, we don't seek medical treatment like we should. We don't have and develop the value of being a part of even some of the milder child stuff that is happening in the community. So the first thing is ambivalence toward seeking and getting treatment is a big thing that's happening in the community. The other thing is we all have heard all the stories around the Tuskegee situation. And, some people say experiment, but the idea was Tuskegee and COVID coming out, more people are now aware of the fact that COVID wasn't necessarily an experiment to, you know, to give somebody something. It was preventing people from getting the type of treatment that they needed, right? That they knew was available to certain people, and we didn't get it. So we still have a misconception about that. And that's what you hear in the community when we're trying to convince people to go and get a vaccination against this deadly virus, COVID. And so now that we've learned so much about COVID, so much about how we need to be addressing the COVID, now that we've learned these things, we have to now figure out how do we get more people to understand the misconceptions. And it is conversations such as this roundtable that gives us an opportunity to create a conversation, be engaged in a conversation that will have people listen in, tune in, and hear some just letting them put that stuff in. They're trying to kill us, you know. That's for white folks. That ain't for Black people. They designed this stuff against us. So these are some of the things you hear in the community about or against people taking the COVID and getting the vaccines, getting the boosters, and so forth and so on. And so for the record, I want to say that I have definitely gotten both my shots and been boosted.
Thank you for that perspective. This is a really important point and an excellent segue, because our next sort of line of conversation is, what, in your opinion, should we be doing as individuals, then as a community? And of course, since I'm speaking as community outreach from an educational institution, what can we do? So that's a three-part question. So we're going to start from the individual perspective. What could we as individuals do to help mitigate this long COVID?
So number one,
it's a scourge.
Number one, I'll dive in first, and then the doctors can follow me with all the technical and the real specific stuff. Number one is, you said you were an educator. I applaud you for all the work that you do over there at Howard University. We have to continue to educate the public. We have to continue to get information out there. We have to figure out new ways to get it out there. We have to be able to figure out how do we get more of our young people aware of what we need to be doing to fight this pandemic, COVID-19. And then that in turn will help us be able to address long COVID in a more strategic and more effective manner. So the biggest thing that we need to be doing is we need to be putting a lot of information into the community about what this COVID vaccine is about, what these vaccinations can and are doing for us, and how important it is for everybody to get the shot, take the shot, and ensure that everybody around them does that. And we wear masks until we get it straight.
Does anybody else have a perspective to share about what we can do as individuals? Because my next question is going to be about institutions and policymakers, but it's the same question.
Mine remains the same. Those of your friends, peers, colleagues, people your neighbors who have not been vaccinated at all, try to convince them to go get the shots. Those who have not been vaccinated at all, because there are still some of them. I mean, I still get surprised when patients come to the clinic and we are trying to schedule them for colonoscopy, and we ask, have you been vaccinated? And they say no. I mean, it's like, what are you waiting for? There was even one that I saw not too long ago, and she told me she's not been vaccinated. And I said, okay, let me ask you this. If you are afraid that we are going to turn into zombies as a result of COVID vaccine, what would life be if you are the only one that is remaining alive and the rest of us are dead? And she said, oh, you put it in a flip pattern, rather than thinking. I said, okay, if you are afraid of the vaccine because you think the vaccine is going to cause more problems for you, the rest of us have gotten the vaccines. Suppose we die, you'll be the only one alive. So I flipped it back to her and she said, okay, I'll think about it. But there are still people who have not, gotten even one shot. So I think a lot of emphasis still needs to be placed on that. Before we then talk about, the fourth shot or the fifth shot, we know about the first 3 doses. Let's focus, and at least that's an individual responsibility, and we can still emphasize that.
We are actually going to, as an upcoming topic of our series, we are going to focus on the vaccine, and we're going to invite questions in the discussion about what the concerns are and see if we can work through those things. I think it's not just my opinion. The fact is that there is a sizable part of the population that is not vaccinating, and rather than just say, look at you, you're not vaccinated, really get to the root of what the concerns are. Perhaps people are feeling that they would like to have more information. And so we need to be in a position possibly to help them with that, create safe spaces. I'm hoping that since I've seen so many people still on the call, that this is considered a safe space to have those kinds of conversations, and not just, you should get it, but really dive into what the concerns are and what it might take for somebody to consider getting that.
Karen,
Sorry, go ahead, Dr. Brim, please.
If I may just add something to what Stewart just alluded to. So as of now, and because he said that Black men generally don't go to the doctor, which is a fact that we will observe right now, and it's not just the Black man, but men in general, they don't have the same sensitivity or the same predisposition to go to a doctor like women. As of now, most or the numbers of women that are claiming to have PASC is more than the one in men. So and this is kind of skewing to a certain extent the real profile, because more women are speaking up about what they are feeling. They are more alert to their changes in their own overall health. So, and this is exactly the reason why I stated earlier that resilience is good. It's fine, but in a post-pandemic era like the one we are in right now, we have to leave it on the side, because we need to be alert and aware of any changes in our own health, whether we are male or female, because we are likely to be hitting a major public health crisis if we don't take care of this long COVID, if we don't understand it correctly, and if we don't design the proper ways to deal with it. And one of the best starting points for it is to recognize it where it is, to report it, and not to be shy about talking about whatever anyone is feeling as changes in his or her overall health.
Dr. Carell, I see you nodding. Do you have something to add there?
Oh, no, I completely agree with everything that's been said. I enthusiastically agree. I think, yeah, we all have to be, responsible. We have to make decisions that are, our decisions about our own health affect our community and affect other people, our family, our friends, our coworkers. I mean, everything, right? So totally think that's really important to take into consideration. If you don't get vaccinated, right? It's not just that you're going to spread the virus more, but you're going to get sick and somebody might have to take care of you. And that's going to be, that's going to affect your people you love and your community. So it's really just so it can't be overemphasized, I think.
Hello?
So we actually have a question that's come up on the chat from one of our guests, and I'm just going to read it. And I'm going to invite my ID professionals. Unfortunately, Dr. Teferi had to leave, but it reads from Ms. DaCosta. I have not been vaccinated. I don't plan to get it. Why should I get vaccinated when I have already had Delta and took me 2 months to get better? Due to my health conditions, why should I risk my life when even with the shots, you can still get it and you can still die from it? So I think I will take my chances with not getting the shots than to get them. I really thank you, Ms. DaCosta, for your question, because I think that it is reflective of what our guests have been saying about the concerns about taking the vaccine. Thank you for your question.
Taking advantage of the silence, I also thank you for your question, and it gives me an opportunity to say what I've said to so many people like yourself. There's some people I already had it, so I'm good now. I don't need to get it. You still need to get it because your immune system was strong enough to repel it and help you get through it. When you went through it, it doesn't mean that your system is going to be strong enough to continue to be able to fight it off if you get it, should you get it again. So that's the most or the most convincing. I don't know if that's convincing for you, but for me, I know people who got it, who were able to fight through it, didn't get the shot, and then got it and passed from it. Someone who I know personally, and when you know somebody personally and you're there with them and it happens, you get to say to people, I'm glad that you were able to fight it off on your own. But you may not be able to do that should you become ill again. And we know that over time, our immune system gets weaker and weaker. This is why when we first began to address COVID and we had the vaccine in its early stages, we were giving it to all of the people who were most vulnerable and seniors because of your weakened immune system. And so every time that you go through something medical, it weakens your immune system. You get a chance to rebuild and get stronger again. But if there is anything I can say is you should get the shot because you got a better chance of fighting it off if you get it again. And if you haven't had it, for those who haven't had it, just taking this opportunity, get the shot so that you don't have to worry about whether or not you're going to survive.
Is there anyone else that would like to add to that? I see you unmuted yourself, Dr. Carell.
Oh yeah, I just wanted to say I think that a conversation, because I have a lot of conversations about vaccinating, and like why people get it, why people don't get it, and one thing I tell I kind of tell all my patients is I would never tell you to do something I wouldn't do myself, or at least don't try to do myself, and that doesn't convince many people maybe, but I think that I think that framing, like kind of the way to frame the conversation, I like to do it is I like to say, I think that it's the vaccine really isn't a risk when you compare it to the risks of the virus, because the virus can be such a devastating, I think it's going to be such a devastating illness. And even if you don't end up in the hospital with it, the long-term effects can be just so devastating. And the thing about the vaccine is there really isn't, there are like any other medicine, there certainly are side effects to it. But I think one way to kind of talk about the vaccine is to kind of discuss what the risks actually are. And I think when kind of boils down to is that they're very, when you talk about the risk of the vaccine and the benefit of at least minimizing a horrible illness like COVID, which can be so devastating, I think that framing it like that is, I think, a kind of a positive way to approach the situation.
Thank you for that. I'm again looking at the clock, and I want to respect people's time, but I do think that we've had a really, really robust conversation about this. Not to cut anyone off, because there's just a tiny bit that we need to wrap up here, and so that people can continue with their evenings, but we will have a completely separate, I think it's worth it actually to have a completely separate call about vaccination and all of the conversation around that. So as you registered for this call this evening, you will be on our contact list if you agreed to do so, and we will reach out to you and let you know when that call will be. We do have another call in 2 weeks, and that's about dealing with the psychosocial aspects of COVID. But just as a wrap up to this evening, I would like to thank all of our special guests, giving of your time and your expertise and just your willingness to have a conversation with us this evening. So thank you very much to Dr. Teferi, who unfortunately had to leave, Dr. Brim, for your clinical perspective, your clinical and your data perspective, Dr. Carell and Dr. Layemo, and also our co-producer this evening, Mr. Reynolds. Just in brief, to wrap things up, to follow on the conversation of what can be done on an individual and a wider level, Howard University is actually doing research on long COVID. Howard University is one of the centers for the RECOVER study. So I would invite Dr. Brim and Dr. Layemo to speak very briefly about what that is and how one might become involved. It's a very important study.
Go ahead, Dr. Layemo.
Unmute.
Sorry, I didn't realize I was on mute. The study is RECOVER, and it's about studying the long haul or the sequelae of COVID-19. Because just like the panelists have shared and the community members have also mentioned, people do have some lingering effects after the acute process is over. So the study is about recruiting people from the wide spectrum, from the community, from those who do not have, who never had COVID infection, those who have mild COVID. There are some people who didn't even know they have COVID until somebody checks them because they didn't present with anything. Those who are hospitalized, those who have mild symptoms. So it's cutting across the entire population. And the goal is actually to recruit about 900 people in 2 sites, in 2 additional sites with us. So the whole goal is to study COVID-19 with respect to people developing PASC, and it involves taking a history about what happened when they had it, what are the current symptoms they are having, and to be able to get some specimen which can also be studied to actually know more about the problem that they are having. So the study is a longitudinal study that we will follow them over time to see how things evolve so that we can learn more about COVID, and hopefully the information gathered will then help us in dealing with it, because one of our fears is the fact that this may be for the long haul for us as well. So we want to learn as much as possible as we can from this study so that we can all benefit to protect ourselves from the effect of COVID-19 as we have it. So this is what you are seeing on the screen is the poster for the study in terms of our opportunity that we want to understand the long-term effects of COVID. So that's what the study is about, and it's called RECOVER.
Dr. Williams is still on the call. I would invite you, Dr. Williams, to speak very briefly about the other study opportunity that we have ongoing. And if not, I'm happy to say a little bit about it. It's basically an online survey to help us understand what's important about life beyond COVID and to help researchers find the best ways to share information. We were just talking earlier about how to get this information and knowledge out there. So after this meeting is over and in follow-up, we will send you the information if you are interested in participating, and you're eligible to receive a gift card up to $100, depending on how much of the survey you end up completing. That concludes our call for this evening. Again, this was just so amazing, and I'd really like to, on behalf of the RCMI, Dr. Williams, extend our thanks to all of you who submitted questions and engaged in conversation. And Our next call will be on April 28th. Again, the psychosocial effects of COVID.